general, internal, gynecology, obstetrics, and so we dealt a lot with it was a very different environment back then. You could basically, there wasn't any meaningful use, and you would sell a system to a doctor, and if it was a solo practice, it would be about $30,000, and basically a lot of that was a personal check, and he didn't buy a nice new car that year. Very different environment than today.
All right. Dr. Mike, quick intro.
Mike Koriwchak. I've been a ear, nose, and throat doctor in Atlanta for a little over 20 years. Of 10 years, we've had EMR, and of the 10 years we've had EMR, 5 were before meaningful use and 5 were after. I've got about 40 years experience in information technology, been writing my own code since the 70s and write my own code for our own EMR, and have been blogging for about 5 or 6 years and have a radio show on healthcare policy that's every other week.
Very cool. Thanks for coming. And Mr. Chambo, your first time on the air with us.
It's Mr. Chambo. My name is John Chamberlain. I am a recovering hospital and physician practice executive, and been in this business for close to 40 years, and find renewed energy. I've been working a lot in the direct primary care space, working with physicians and employers to help find some solutions to easy and quick access to primary care at a reasonable rate.
Excellent. Thank you for coming. So sticking with the theme of the chat, why don't we start right at the top and say, are we in for a doctor shortage? Do you agree with this prediction that it's the AAMC put out? They are expecting up to 90,000 doctors shortfall as of 2025, about a third of those being the primary care doctors, and the rest, the balance being all different specialties. So what are you guys seeing out there, and do you think that's accurate?
I'll jump in. Yeah, I think we're in one.
Okay.
I don't think it's coming. I think it's here.
Everywhere in some places?
Oh, I think it's probably regional to a large degree, but when you have 10 to 14 day waits to get in to see a primary care physician, that's an average, and I'm not sure if that's national or regional, but there's obviously a problem.
Okay. Chuck?
I'm actually in a very noisy environment here, so I'm going to jump off. But I see Randall Oates here, who sells an EMR that we used to compete against. So I'm hoping that to see him on Blab. So I'm going to jump off and continue to listen. All
right. Yeah, absolutely, Randall. Or if anybody else wants to try to jump in, have at it.
Yeah, I think clearly there's a doctor shortage, and I agree that it's not a matter of if it's coming. I think it's already here. And, from what I've read, it's probably worse in rural areas versus urban. But, I think it's pretty obvious that it's coming. And, I've read in some places that, with Obamacare adding more patients that are at least carrying a card as opposed to actually having access to care, that, that's getting only worse. I think it's a no-brainer that the doctor shortage is pretty much here. It's only a question of how much worse is it going to get.
Gotcha. Yeah, and some of the digging I've done in prep for this chat, I definitely come across where there's shortages in certain regions, and the obvious ones being rural, but there's some pretty rural states. So there's entire states that are having this problem. And something else that I come across in the last few weeks was the concept of the Dartmouth Atlas's, I hope I'm saying this right, the care-sensitive markets, which basically, even if that's the wrong term, the idea is that areas of excess capacity tend to do more procedures, tend to have more admissions, tend to give more care. And because of the way the reimbursement models work, they are incented to give care and to fill that capacity. And if you put those two concepts together, our current reimbursement model is allowing areas to have excess doctors that they don't necessarily need to do care that doesn't necessarily need to be done, while at the same time allowing other regions to have the shortfalls. And there's a obvious problem and a obvious path where we could do something there. So what do you guys think about that? Do you agree in that with that whole care sensitive concept that the Dartmouth Atlas pointed out?
Well, it depends upon how you define excess. I mean, it's, I don't know that there's an absolute standard that tells you how much is excess or whether that amount of care that's being given is really what's needed. And I don't know how. I mean, did that study give you some sort of absolute yardstick that says X amount of care in a rural area or in an urban area is too much care, or how did they decide what was too much?
That's a great question. I don't know off the top of my head, but I'm making a note to dig in.
See if you can find that out, because obviously so many of these things are written with a particular point of view behind what's going on. And if somebody like that is either arguing in support of certificate of need laws, which is the other place where this discussion comes up, or they're trying to argue in favor of this value-based reimbursement or value-based care, which is again one of those concepts that if you talk about it from 50,000 feet, you can't really argue against it. Nobody would argue against the concept of value-based care. But if you and I have talked about in the past, Don, is how do you measure value? How do you define value? And in this context, how do you define how much care is too much care? I mean, you could argue that maybe where there's that the number of doctors in an area is not a rate limiting step, that the care that's given is free to come up to the level it's supposed to be.
No, that's a great point. That's why I love bringing this stuff up in these contexts, because you read it and they make really good cases for it in a vacuum, and getting that outside perspective on it is huge. So I'll dig in. I'll find out what their definition was of both sides. How do they decide it's excess capacity? How do they decide it's excess care? We'll come back on that in the coming weeks. John, did you have any? Actually, Jamie, I just want to say welcome.
How you guys doing?
You can jump in.
Hey.
Excellent. Now you want to do a 2-second intro so everyone knows who you are?
Sure. Jamie Edwards. I'm the CEO of two companies, Language Access Network and CareNection. They're sister companies in telemedicine. But prior to that, I was the CEO of a ER hospitalist and anesthesia group in Southern California called Emergent Medical Associates.
Awesome. And you're also from Buffalo, so.
I'm also originally from Buffalo.
All right. John, I just want to jump back to you. Did you have thoughts on that whole care sensitive concept? It looked like you were going to.
I think the whole concept, John Winberg is the guy that originally came up with the original Dartmouth Atlas, and he was really focusing on care differences, and I think it's probably morphed into what we've been chatting about here recently as far as the excess capacity and filling that capacity rightly or wrongly. I don't know a lot about it. I'd like to look at it more to see if there's some basis for that. I know Winberg's work originally was very interesting in that from even within the same city or certainly the same state, prices and volume for the same DRG were all over the map, pardon the pun. But I think his stuff is generally been recognized as valid. I have not seen this most recent one that you're talking about, Don, but I think it'd bear looking.
Okay, great.
Yeah, so the one thing I was going to say really quickly is I'm not really too familiar with the work, but what I've noticed about physician shortages is that they're really driven by payer mix, right? So even in big cities such as LA, which is where I live now, there are hospitals that have a really hard time staffing due to just the payer mix. And so, when you have a facility, where doctors are being paid $300 an hour because they have a great contract with Blue Cross and Blue Shield and this other hospital doesn't. And by the way, there aren't that many great Blue Cross Blue Shield contracts out there, so I should be careful with the example that I use. And then the hospital 10 miles away, who's in an underserved area, who sees mostly Medicaid and Medicare patients, has to pay their doctors $150 an hour. It's really hard to compete. And so for me, it's about these microclimates of where the payer mixes are, because even in urban areas where people largely wouldn't consider, a doctor shortage to be in place, there are for certain communities and certain hospitals. And there are certain rural areas that have great payer mixes that can staff great physicians. So I think it's really payer mix driven and payer mix dependent.
Yeah, that's a really good point.
Good point.
I had a doctor who couldn't join us today that sent me some notes last night. His name's Neil. Desai, and he made a point along these lines too. He's a primary doc, and he said that a lot of the patients he sees should be going to specialists, and in their words, they can't afford the specialist. They said to him, "You're the only doctor I can afford to come to see," and they're coming in and basically getting not the specific care that they need. It's better than nothing, but it was an interesting point: is that the specialist wouldn't take the Medicaid, he will, so that's where they're going to end up, and they're going to get what they get.
Well, agreed. And the common theme with all these issues is an overdominance of the third-party payer. It creates perverse incentives. It creates these unbalanced, distorted markets. You know, what's supposed to happen is if there's a shortage of docs in a certain area and it's underpriced, then the price would come up to market value, and you know, folks would come in to fill the space. But you know, when you fix prices, whether it's Medicare, Medicaid, or Blue Cross or Blue Shield, you know, you completely destroy the whole supply-demand dynamic, so that you can, you know, bring the supply in to meet the demand. That's what's supposed to happen when prices can float. You know, you hold prices artificially low, there's no product available at that artificially forced low price.
Yeah, right on.
There's no supply.
That's right. At that price, there's no supply.
Yep. Yeah, that was one of the points that we dug into in the post coming into here. Try to jump back in here.
But on a bigger note, you know, the whole doctor shortage is even bigger than that. I mean, it's, you know, there's been at least 30 or 40 years, you could argue even more, of, you know, regulatory hostility towards physicians that make, you know, all the reasons that we went into medicine, you know, more and more remote. And, you know, there's a lot of folks around that do like I did. You know, my son is taking a anatomy and physiology course as a senior in high school. He's getting very interested in this. And if he said, you know, maybe I'd like to be in healthcare somewhere, and I say, well, great, but don't be a doctor. You know, and that's a complete cultural shift from what it was a generation ago, when you had whole families where it was, you know, father was son, there was a doctor, kids were doctors, sons and daughters, the grandkids were docs. Now the culture has completely turned 180, and we're all going, don't do that. So
Mike, I'm the sixth of six generations of physicians. Unfortunately, or fortunately, as the case may be, I decided not to be a physician. I think my ancestors might be unhappy, but given the circumstances, maybe not.
No, I'd say, you know, you probably made the right call. You know, the vast majority of docs, if you look at interviews, wouldn't go into medicine again. So,
right.
You know, it's all this stuff. It's over present third-party payers. It's, you know, the whole regulatory structure from Stark to anti-kickback to HIPAA to OSHA to meaningful use. And it becomes the vast majority of our energy is no longer available for patients.
Well, you don't get to practice medicine anymore. You practice insurance and regulatory, and how do you make a living, reimbursement, all those things. You're not really practicing medicine anymore. You're just trying to stay afloat.
Yeah, I think it was, we just had a conference, and ZDog MD was there, and he kind of gave a talk, and one of his talks was centered around the fact that EMRs are just glorified cash registers, right? And so our physicians have had to focus on, you know, that type, you know, documenting so much and how that record is documented as opposed to spending time with the patient. And, you know, Mike, to your point, I think we've spent a lot of time in society for the last, you know, I've been in healthcare for 10 or 15 years now, vilifying the providers. And I'm not a physician, you know, I'm an investment banker and private equity guy by trade, and then became an entrepreneur, and got involved because the first company I managed was actually my uncle's ER group, right? So nepotism on that part and landing me my first CEO gig. But the fact of the matter is that it was me reminding the doctors how amazing their jobs were, right? Like, they had lost that vision. They were so overwhelmed by documentation, malpractice suits, feeling like the patients felt entitled to their care, that they really felt mistreated, and they had lost their mission. And that was a sad thing. And I was the non-doctor in the room saying, what you guys do is amazing. You save lives every day. How great is that? And, you know, they had lost that. They had lost that because it had been beaten out of them by the system, if you will.
Well, there's the problem is, and I think, Don, you've heard me say this before, is that docs by nature are pleasers. You know, we pleased our parents, and then we pleased our teachers, and in college we pleased our professors, and med school and residency, we pleased our attendings. And then we got out into the real world, and, this whole pleaser trait becomes maladaptive because the competitive stakeholders, the hospitals, the insurance plans, the bureaucrats, the legislators, all want to, they regard it as a zero-sum game. They want to gain at our loss. And so it just makes the practice of medicine, very, very unpleasant. And, as a result, the shortage, I think, is going to get worse instead of better. I mean, if you're a talented kid getting ready to enter college and declare a major, and you've got your choice of, several fields to go into, why would you pick the one that takes the most amount of training and yields the least amount of respect and reimbursement at the end?
And lifestyle.
And the most amount of investment, right?
Yeah. I mean, it's, who would sacrifice their 20s for the environment that we have now? It's very, who would? If I had to do all over again, the only thing that keeps me in it now is all this extracurricular stuff that we get to do, like what we're doing right now.
Right.
It's where where the satisfaction and the ray of hope comes in. But if it were just, if someone told me all I could do was go to work every day and go home, I don't know that I'd stick with it.
Right. Yeah. The whole concept of not recommending your son to follow in your footsteps. So that was, something I came across a bunch too, is, think about the concept of a net promoter score, and generally in marketing, it's just the simple, oversimplify. Would you recommend this to a friend? And it's the numbers I came across are 1/3 of doctors. The answer is no, absolutely not. I would not recommend somebody else to become a provider. From your perspective, it actually sound like you think that number is a little higher.
I think I've seen, and I can't quote you chapter and verse. I think it's higher than that, probably on the order of half or slightly more. But I'm pulling from something I hadn't looked at in a long time for that number. So I'm not really
sure. Either one of those numbers is huge, is impactful, and people making that decision. And to the point of the primary docs earlier too, that being one of the big shortages coming up, and the different incentives of driving people to be primary versus not, the lifestyle issue. I came across some docs talking about, if I become a primary doc, not only am I on the lower end of the reimbursement scale, and not only am I kind of squeezed out in a sense by the system, because my job is to prevent more care from happening and to do the overall care coordination, and the system doesn't quite handle that properly on the reimbursement standpoint. But I also get to be on call. And that means that nights and weekends, my lifestyle is being impacted as well. And, one more thing that maybe all the specialists wouldn't have to deal with. So I thought that was an interesting point.
Well, specialists deal with call too. Make no mistake there. And sometimes for specialists, it doesn't matter if you're on call or not. I had a situation this past weekend where I wasn't on call, but the patient who had a potential problem, really, was not willing to entertain being touched by the person who was on call. And so, had there been a problem, I would have had to drop what I was doing and, walk away from my wife and kids because we had an event that we were at, and go and, do a tracheotomy on this person. Fortunately, it wasn't required. But, a lot of times with a specialist, I mean, you may be the only one that can handle a unique problem. And, in some senses, I'm on call 24/7, 365, even if I'm not in town.
Gotcha. So not so cut and dry there on that example.
It's not so cut and dry. It's and with specialists, sometimes the more you subspecialize, the more the less replaceable you become on an hour-to-hour, day-to-day basis.
Okay, that makes sense. And so we got a question popping up in the corner here. I want to know how many of you practice or embrace holistic medicine. Dr. Mike, you're the only practicing physician here, I believe, right? Any thoughts on that?
Yeah, sure. No, I took a course when I was an undergraduate on alternative forms of medicine. And, one of the lessons that came out of that is that, the folks in the white coats don't have all the answers. And anybody who pretends that they do is kidding themselves and kidding their patients. So, if someone comes to me and they've got, a solution that is holistic, at the conceptual level, I'm very enthusiastic about that. And, it comes out of, you need to engage your patient. I mean, and the stuff that they bring to the table is something that you need to understand and respect and consider in a big picture plan, even in a specialist office. So I'm all for it. The only time I ever reject somebody's alternative medicine plan out of hand is if they've got a cancer diagnosis or something similarly dire, and there's something that needs to be done pretty quickly and needs to be done pretty definitively, and that's the only time I ever challenge that. The other 95% of the time, if they've got a solution, whether it's holistic or any alternative model, I'm all for it, as long as it's not hurting anything.
Excellent.
Yeah, my experience on that front, when I was working with the ER group, is we actually worked on putting retail clinics in Whole Foods, and they were going to be staffed with naturopathic doctors. So I started really digging in around what a naturopathic doctor does. And the interesting thing, and you hear the difference between sick care and well care now. We kind of talk about it all the time, right? Is that naturopathic physicians are really focused more on wellness and treating the body as a whole, as opposed to fixing the one acute issue that they're faced. And we're putting our providers in this position these days where they need to be focused on the sick care when they could be focusing on the well care. So, in support of Mike, it's kind of all of the above, right? The more disciplines you can bring, where a patient is talking to a nutritionist, might be talking to a naturopathic doctor, but everyone's working together as part of care team so they can complement each other, is what's going to be best for the patient.
Awesome.
The one agreed, James. The one discussion on quality of care that I've ever found that actually made a little bit of sense was an article that discussed a concept called contextualization of care. Mm-hmm. Right. The difference is, let's say I treat somebody for acid reflux, right? In general, that's going to involve a medication plus some dietary guidelines, reduction of alcohol, caffeine, chocolate, et cetera, et cetera. Now I can click all the boxes to be a quality doctor if I toss the handout at the patient, toss the prescription at the patient, say, do all this stuff, see you in 6 weeks, and walk out of the room. That checks all the boxes, right? In the world of meaningful use, I'm a quality doctor because I gave him a handout and I, clicked all the boxes. But there's minimal quality there because there's no contextualization. So the contextualization is, I talk to the patient and I ask him, how much coffee you're drinking, how much alcohol you're drinking. It's amazing how people will answer no to the alcohol question. And you go, well, how about a glass of wine or two at night? And they go, oh, yeah. I have a glass of wine or two every night. But if you just ask them generically about alcohol, the answer will be no. And, that's the difference. It's contextualization. You say, look, in your particular case, here's what's on the guidelines that apply to you. And that's also the moment that if they have a holistic or whatever, whatever they bring to the table, is that you sort of build all that in. And this particular source, I called it contextualization of care. It seemed like the only quality care discussion I ever saw that made any sense.
Yeah, and you definitely need some time to do that too. You can't have a rushed conversation and be able to get to that level of contextualization.
Absolutely.
All right, awesome, John. How about you and the practices that you're working with? Anything on anyone dealing on the holistic front?
I think there are a number. An unfortunate situation with a coworker of my daughter's. She lives in Austin, Texas. Was diagnosed with cancer and tried nothing but a naturopathic approach, and it was too far gone. And so I think to echo what Dr. Mike says, there are certain instances where I think you've got to step in as a physician, and I'm not one, but I'd certainly feel this way and take the bull by the horns and recommend against that. But as far as holistic care, we have a number of those in the area in which I live, and I think they certainly have their place. There are a lot of folks that feel that they are being helped by a holistic approach, and that's all well and good. But again, I think it comes back to Dr. Mike's comment. It depends on what the ailment is, what the disease is.
Very good. All right, and then transitioning into what was our third question was always my favorite. So what do we do about all this? And two kind of things for context coming in. One is that the group that did the study that I was referring to, this AAMC, their quote was that the physician shortage will persist under all likely scenarios. They ran models where they had additional advanced practice nurses, greater use of alternative settings like retail clinics, delayed physician retirement, rapid changes in payment delivery. They claim to have run a whole bunch of these different models and still end up with these same projections or similar projections for physician shortage. So ultimately they're saying, and this is always true, there's no silver bullet. There's not, if we do this, everything's going to be good. But what are some of the things we can do to start taking a bite out of this? And kind of one other contextual thing is Shahid Shah, who is normally with us on this, couldn't be here this week, but he threw out some thoughts to me last night about the shortage comes based on how we're doing things today and how we're looking at them today. And a lot of that is based on like titles and certifications and things like that, who's allowed to do things. And like we talked a little bit about the restrictions on direct primary care and who can do different things last week, I think. A similar concept is like, are there pharmacists out there who can help with some of the care of the providers that they're not necessarily allowed to today based on some of the rules and laws that are out there? So his suggestion was, if you think about it from the standpoint of open up who's allowed to do things, and certainly Jamie, you'll, from the telemedicine side, I think have some comments on that. If we change that model, what can we do differently? And how can we address this? Why don't we start there, Jamie, with the telemedicine stuff, because that's got some really obvious issues with the cross-border licensing issues and everything else.
Yeah, so I'm a little bit of a Peter Diamandis disciple, right, who founded the X Prize. And one of the things that he believes in right now is that, we don't have a food shortage in the world. I'm going to draw this story into a bow for you right now. But what we have is a distribution problem, right? I feel the same thing could potentially be true for physicians, which is that, yes, from a geography problem and standpoint, we've got doctors all over the country, but the technology can help link everybody together in a way that allows us to solve a little bit of that supply-demand imbalance. Teleneurology is an example. Those doctors typically aren't located in rural areas. But the fact of the matter is, if the Mayo Clinic started ramping up their staffing and had that training, then many people in the country could have a telestroke consult from a Mayo Clinic or a Cleveland Clinic or somebody like that, or even a great local hospital that's 30, 40 miles away or 300 miles away, as the case might be. So it's going to break down. Telemedicine is going to really break down those national barriers, and then you get into these licensing issues and the credentialing issues at local institutions and in the states. And that's the interesting battle that's kind of taking place right now. Are we going to get a federal license for a physician to practice medicine across state lines, or are they going to continually have to, apply for licensure in a given state? And the interesting thing about that is that really goes to the transaction cost model that has been applied to stock trading. If the transaction costs are so high, then it impacts the supply. And, it's going to be breaking down those things that I think really help break down the barrier. But yeah, telemedicine can help bring a lot of value in terms of connecting everyone together and getting everyone the specialties they need at the right time. It also segments out the pricing. So, when you can share the network effects of a physician, as opposed to having someone dedicated who might not be fully utilized in their current role, we can fully utilize a doc using telemedicine by allowing that doctor to see patients at multiple sites. And so there's a lot of value there as well.
Awesome. Thank you.
Agreed. I mean, and I think, James, you're saying the same thing that I'm going to say, which is, we need to decrease the regulatory burden, and we need to decrease the role of third parties so that, I, for example, can go out and invest in telemedicine infrastructure and, number one, be free to bill for my services at a fair market value and get paid that without a huge amount of overhead to collect an insurance claim, and be able to recover the investment and be able to do it without fear that somebody is going to come out of the woodwork and try to nail me for some sort of regulatory infraction regarding literally the tens of thousands of pages of regulations, maybe hundreds of thousands, that apply to the behavior of physicians. Will I be violating a Stark law? Will I be violating an anti-kickback law or a HIPAA law? And so people have great fear in extending themselves into these spaces. No one wants to be the first, and no one wants to be the second or the third or the 10th until a few years go by to see if the early adopters get nailed. And so there's got to be some sort of regulatory relief and some ability for us to invest. I mean, remember, the Medicare reimbursement for a patient visit is X. Whether I'm a crappy doctor and I do things with minimal requirements fulfilled, it's X. If I try to go to a center of excellence level the payment's still X. So where's the financial incentive to excel? Where's the incentive to distinguish yourself as a center of excellence when there's the third party forces that price to be fixed? So there's got to be a way. I mean, clearly, if we could bill patients directly for telemedicine, heck, half the follow-up visits I could do by telemedicine.
Absolutely.
Even for people who live in Atlanta. I mean, it's a huge pain in the rear to take a half day off of work and get in your car and drive someplace and park your car and pay for parking and wait a half an hour. I'd love a system for, follow-up visits in the case of a patient who's doing fine, which you could figure out up front, and, do what we're doing right now. Right? Same technology. I got 3 faces on this screen. I could do this with one face that's the patient and maybe one who's my medical assistant. And, we could easily work out if everything's doing well. 99% of what we do is conversation in those. But I need some kind of legal protection for that model of delivery. And I need a way to bill for it that allows me to recover my investment. Because right now, if I try to bill for what we're doing right now, all I'm going to get is laughter.
Yeah, those are great points, Mike.
I think a couple of other things are entering into the situation. One is we're within one state, and it may have already passed, for all 50 states where nurse practitioners have prescriptive authority. I think Florida has been the only holdout. That's a plus. And recently, I've been getting calls from interventional cardiologists as well as orthopedic surgeons. You can probably understand the orthopedic side a little quicker, but about getting out of their specialty practice and going into a direct primary care model. They're up to here with insurance, reimbursement, health system issues, and the interventional cardiologist that's contacted me says I could get office space at a friend's office 3 days a week and make a living and not have any of this to put up with. He's got a panel right now of 12,000 patients, which is just absurd. So that's another potential.
12,000 patients. I think the
12,000 patients.
Federal recommendation is 3,500. So
right,
he's 3.5 doctors basically.
Yes.
No, I'm going to have to duck out. I've got examples that are full. I'll make one parting comment. The group that I work with, the Doctors for Patient Care Foundation, we're having a meeting October 14th in Dallas that's jointly sponsored by us, the Physicians Foundation, and the Texas Medical Association. And the whole meeting is going to be on direct primary care.
Fabulous.
That model is clearly, a potential wave of the future that bends the curve favorably, I think, across all the parameters that you look at. But more on that as we develop the meeting. But it's definitely the direct primary care thing's awesome.
Cool. Is there someplace online we can get some more info on that, Mike?
Yes. Yeah. As it comes available, we're just sort of putting it together right now. But,
Got it.
It's going to be a pretty cool meeting, but it's October 14th. Anyhow, I'm going to drop out. Don, James,
thanks, Dr. Mike.
We'll see you guys soon. Thanks.
All right, take it easy, guys. I got to duck out too. Don, thanks for arranging this. Nice to meet everyone.
Yeah, thanks for popping in, Jamie. So if anybody else wants to jump in, we can keep chatting for a few minutes. John, you got any more thoughts on what we've covered so far?
Well, I think one of the things that Dr. Mike brought up as far as being able to do visits non-face-to-face, how many visits do physicians see today that are reimbursement driven as opposed to clinically driven? Returns for renewing prescriptions, those kind of things can all be handled with, for lack of a better term, e-visits. And the last place people want to be when they're sick is, as Mike said, having to drag yourself out of bed, get dressed, and if you don't want to look like a slug, because you're going to be sitting in a waiting room with other people, and the waiting room is a very apt description because that's exactly what it is. In a direct primary care setting, it's a reception area because, A, you're not going to be there very much, and it's as Mike said, it's definitely worth taking a harder look at this particular model. And I think, again, the doctor shortage, I noticed one comment from one of our attendees that it might be overrated. Well, I think it may be in certain areas, but there are certainly parts of the country that are the doctor shortage is very real.
Gotcha. There's a question down here from Monty Henry asking about government restrictions on the number of the residency restrictions. I actually did come across some of this in my research too. I'm just curious if you're familiar with it, John, is that effectively the number of residencies are governed by the Medicare funding. That's largely what makes them happen at the teaching hospitals. And they are capped by some thresholds that were set back in 1997 and have not been addressed since. Are you familiar with that concept at all?
I am familiar with that. In my history, I've had responsibility for working with medical schools, certainly their residency programs and healthcare facilities. And that is correct. That's almost 20 years old, and the needs have changed drastically in that time. I'm not sure what the solution is to that. Do we, look at a way to increase funding, which would then lift those residency caps? I know that bringing on new medical schools, there's a new one that it's actually an osteopathic medicine school that recently opened in Dothan, Alabama. And I don't know if the new schools have the capability to get access to that funding as opposed to the existing schools. That's one way around it. But setting up a medical school is no inexpensive task. So I'm not sure exactly what we can do about it. I would certainly like to know more about it. I see that Monty just added some more information that according to the BBA of 97 can't surpass. So there's a $9.5 billion annual cap on residency on Medicare expenditures. So how do you get other programs besides Medicare to pitch in to those residency programs? I'm not sure there's a way. Is there a way to get private health systems to contribute to that? Because they too are suffering from the lack of appropriate physician coverage.
Yeah, and it'll be interesting to see how this plays out with the shift to value, because a lot of the costs for this are kind of buried into how the teaching hospitals bill out. So they'll bill out, as I understand it, at higher rates for procedures that they do to account for the fact that they're teaching. And as we're trying to move towards transparency and pricing and value-based care and everything else, I'm curious how we are going to resolve that issue, because making that transparent is going to just still be a price tag that's out there, and people are going to look and say, why is it triple there? That doesn't make sense. And they're going to have to shift the way that that's paid for in some way, along with the move to the value-based care. So interesting.
Back in the 90s, I did a lot of work with large corporations talking about, particularly around the Hillary Care timeframe, to understand, businesses just don't understand that you don't get paid what you bill. And that's whether you're a physician or a hospital. And so if you are charging triple, that's all well and good, but it's basically what the payer is going to reimburse you. They don't care what you bill. Then you have to try to go after the patient in some instances, balance billing not being a good idea. But certainly that concept of the way hospitals and healthcare providers are reimbursed doesn't stand true to normal business practices.
Yeah, absolutely. That could be a whole show on its own, talking about that stuff.
It could.
I've dug into that a lot recently, and it's there's just so many layers of complexity and counterintuitive logic. It's an interesting point all around.
It looks like Monty's answered a question for us. Thank you, Monty. That apparently Maryland is supporting its residency programs that they collect from private insurance plans. And in California, it looks like there was a proposal for a $5 per life fee tacked on to insurance companies to help support residency programs. So it looks like there are some options to support that. And again, that doesn't remove the highly expensive course that you have going into medical school and the kind of debt. We talked about it on the chat, but the debt that these docs are coming out with is just phenomenal. It's scary. I'm in the process of working with the University of South Alabama to get in front of their family practice and internal medicine students, third or fourth year, to start talking about direct primary care, that basically we could offer somebody a position right out of school that would certainly go a long way in helping them relieve that debt. And that's something I don't think's been done by a lot of folks in the direct primary care space. There's a couple of options with those docs. You either get them on the back end of their career or you get them on the front end. A lot of the doctors we find in the middle of their careers are scared to death of getting out of the insurance market because they've been beaten up so bad, and I'm sure they get threatened legally in ways that it scares them to think about doing it in a different fashion.
What type of legal fears might they be facing in that regard?
As far as dropping out of the Blue Cross?
Yeah.
Yeah, I mean, there's basically, I think they're veiled threats, but if they're contractually bound, they're obviously going to have their attorney look at what is the result of them terminating their relationship with insurance. I think, and again, I haven't looked at a Blue Cross contract in a couple of years. There's supposed to be a legal out, as with any contract, and as long as you satisfy that legal out, you've got, for lack of a better term, tail potentially or past treatment. You have to be prepared to cover if the need be, and you have to make arrangements for patients to see other physicians or at least assist in that regard. But I don't think legally, other than, I guess, threatening, if you will, or why do you want to do this? We're going to make your life miserable. Right or wrong, that's usually not said, at least not that's documented.
Sure.
But I think
it's an easy way to fear, uncertainty, and doubt. It's an easy way to create
good old fun.
To add friction. Yeah.
Right.
So overall, then the model of direct primary care, I'm only familiar at the very highest level with that. Both you and Dr. Mike are talking about that as a way of breaking free of all of the regulation. Some of that stuff you can't break free of, but obviously from some of the payer contracts and regulations you can. What are the things you get away from, and what are the ones you can't? Can't get away from HIPAA. Can't get away from.
No, and you shouldn't. I mean, obviously HIPAA is overbearing, but the basic concept and the reason for it being in place makes sense. You get away from meaningless use. You get away from all the radio button clicks and all the other things that actually have nothing to do with medical care. So any insurance or finance or health system related requirements that you have currently, the absolute bizarre complexity of most EMRs that are out there currently for health systems and either employed physicians or physicians that interface with that system. You get away from that. I think as far as claims denials, working for somebody else,
unlock your iPhone first,
and being, it's the lifestyle, the ease of practice, relatively speaking. When you're seeing anywhere from, let's say, 8 to 12 patients a day as opposed to 30, and you've already basically, the way the reimbursement works, it's a subscription model. You get paid X amount per individual, or usually there are discounts for families, and you have that money coming in every month. It comes in through credit card, or you have basically a member management company that actually handles all the enrollment, communication, and the fiscal side. So you have money in the bank every month from every one of your patients, or if they fail to do that, then you terminate them, or at least work out a relationship to get it caught up. And you're not required to see patients face to face. It's in your discretion, your best judgment. If you can handle a prescription refill or a follow-up visit over the phone, whether video conference, text, answer questions, there are no restrictions on that. Right now, if you don't see a patient and make a note in the chart, you don't get paid, or your health system doesn't get paid. And that's a very onerous requirement. Just the sheer time involved. I think I've mentioned before that we saw a study recently that said 43% of the average provider's time is spent on data entry. That's crazy.
Yep.
It should be spent on taking care of the patient. Average patient visit time with the patient is 7 minutes. What are you going to learn in 7 minutes? Now that may be different in a specialty office, but in primary care, that's not enough time to adequately discuss healthcare with the patient.
Yeah. To your point on the amount of time and money spent on that data entry, there was a health affairs study came out just a week or two ago, and it said about $40,000 per year per physician, which equated to about 785 hours of work between the staff and the physician on collecting all that data, keeping it recorded cleanly, and then being able to report it. And elsewhere I've seen, I don't have stats I could specifically point to, but the cost of just dealing with insurance in general, with billing, dealing with the billing issues and the back and forth and everything, could cost upwards of 40% of revenue from a primary or from a practice.
That's exactly right. And the yardstick I use when I talk to doctors about it is typical overhead in a primary care office is 60 to 70%. With the direct primary care, it's 30% or less, because you don't have all the insurance and administrative issues and staff that you have to have every day to take care of the claims filings, the billing, the coding, not to mention the claims denials and the typically low reimbursement rate. Again, going back to the what you charge ain't what you get issue. Mm-hmm. So I think from a it requires less office space. You're not having to have 6 to 8 exam rooms to handle 30 to 40 patients a day. You can get by with 2 exam rooms, virtually no administrative space. A lot of the direct primary care docs that I know have maybe 3 physicians in a practice, and they have amongst them 2 staff. So typically you're looking at 5 to 7 staff per each primary care doctor under an insurance-based practice. So just the staff cost alone is very significant. And the reason that works is that the doctors who know how to administer injections and do all sorts of nurse things typically haven't done it because they have a nurse in the office. They have an insurance clerk and a biller and a coder and what have you. But doctors know how to give injections. So a lot of the docs will take on, and that's, again, something they were trained to do and want to do, but haven't done because they don't have the time. Now they have the time, and they enjoy taking care of patients.
Now, the docs that you're working with, are they making a clean break, if you will, from the existing system, or are they kind of ending up in one foot in each canoe type model?
I've got a couple that have done a hybrid model, but they're rapidly moving to a pure DPC model because you don't really have any savings with a hybrid model. That's okay. DPC and insurance based, because you still have to have insurance. I mean, you may reduce your volume of insurance claims, but you're still going to have to have somebody on staff to follow those claims, whether it's 3,000 or 1,000, they still have to be there. So I think the best model for DPC is a pure DPC model, and you do have to make a clean break. It's frightening, but you build that practice while you're doing your normal practice. And a lot of docs that I recommend, interview your patients, pick the patients you want, interview them, and give them an option to go with you on the DPC model. Obviously, and just to be very frank and mercenary, if you have 600 DPC patients that are all train wrecks, that's not going to be good. So, but what this does, in all full disclosure, it brings to this shortage question. If your normal practice panel is 2,500 to 3,000 patients, and you go to 1,000, where the other 1,500 patients go? So you're actually creating or exacerbating the doctor shortage, if you will. But I see that it's not just doctors that have to be the providers in direct primary care practices. Nurse practitioners, PAs to a lesser degree, because they're not. I guess if I looked at the two, the nurse practitioner is more attuned to dealing with the patient and patient care because of their training and their career path. We have a lot of PAs that were engineers at one point, and not that that's good or bad, but typically the advanced nurse practitioners make better DPC providers because they are used to the whole nursing concept.
Gotcha. Very good.
But that's a solution to the doctor shortages. If you have nurse practitioners that are out either staffing retail clinics and or some have established their own DPC clinics, then does help a PH shortage.
Yeah, and I think that goes back to the point of that first study that said you can't just pick one of these things and roll it out and that's going to be your solution, because if you're employing DPC to improve the relationship between providers and patients, as you said, you're shrinking panel sizes, and you're creating, just doing that, you improve one thing, you break another thing. And what do you got to put in combination with that? So now you start bringing in some
I think one of the things that impacts panel size is who are your patients, and are they 75% maintenance patients, chronic patients that are diabetic or whatever disease classification, that it doesn't take a whole lot of effort to monitor on a routine basis. Could that be done via telemedicine or e-visits, whatever you would like to call that? I think that takes off a lot of the load. But the problem there is, if you don't see those patients and, click those radio buttons, you're not going to get paid. So they're on your panel. But if you want to maintain your income, you're going to have to see every one of those patients over a relatively short period of time. I have a doctor friend locally that's got a panel of 4,000, and he says the majority are chronic care patients, not acute, but chronic. And he says it's killing him. And this is a guy that doesn't even have an EMR. He's still paper and pencil. And I said, the first thing I would do for you is get you an EMR that's not necessarily, because he's not a hospital affiliated doc, that doesn't have to be as complex as some of the more popular ones, the Epics and the others. My experience has been with Epic, and it's a wonderful EMR from a standpoint of robust, but it's completely and utterly useless in a primary care setting or an urgent care setting.
Sure. And that was one of the questions I had for you is, what is a good EMR for a DPC setting? Now that you don't have to worry about the MU stuff and certifications and all that.
There are several out there. There's a DPC doc in Wichita, Kansas. His name is Josh Umber. And Josh has, they put together their own EMR, and it's called Atlas.MD. And there is another one called Enlight. Practice Fusion is one that really had a very promising start, but I think they ran into some financial difficulties, and I haven't heard lately, but I think they were kind of on their way to some serious trouble. I think some of their senior management bailed, but at any rate, there are 2 or 3 really solid DPC or concierge-based EMRs that are patient-focused, that gather all the appropriate clinical data and don't worry about the reimbursement data. As far as referral relationships with specialists, all the kind of information clinically anyone would need, they collect, but they don't focus on insurance and or regulatory aspects like so many of these much larger EMRs and more complex EMRs have to do.
Mm-hmm. Gotcha. So I have about 1,000 more DPC questions for you. I feel like we should do a DPC show.
Let's do it.
We're out of time here. And I have a whole bunch more questions. I'd like to get deeper on this. And I know there's a lot of folks that pop in and out of HCBiz that talk about this stuff all the time too. So I think we could build a nice little panel and put together a good show in the coming weeks.
Yeah, I think one other aspect that we'd want to address with that is we've talked so far about the advantages for the doctor. There are huge advantages for the patient as well, not only financially but clinically. So that's another area we could discuss.
Gotcha. And I see one parting question coming in here. I'll let you address that if you have some thoughts. Using some doctors from the Caribbean and Cuba to help alleviate the shortage. I would say certainly if we had telemed in place, there's places in the Caribbean, St. Thomas and the U.S. Virgin Islands, Puerto Rico that are territories, and possibly
absolutely.
That
and
could
I
be
think
an answer.
This has been going on in radiology for 10, 15 years now. When it's 9 a.m. in India, it's 12 a.m. or 12 midnight here. There are an awful lot of radiology readings that are done. There's a service called Nighthawk, and they've contracted with licensed physicians all across the globe. So they get, particularly in the situation of ERs, which need immediate response, they basically are on call, and they're typically a lot less expensive on a per study than, waking up their daytime radiologist in their community. Although that's certainly an option, but yeah, that's a great idea. I mean, I think that's where a lot of telemedicine platforms are going, is they're contracting with board certified physicians or certainly physicians that meet criteria from a quality standpoint, because the same thing would apply if you have a 3 a.m. pediatric need. One thing we've done training physicians or training patients actually is that one of the questions that always comes up about DPC from DPC docs or potential DPC docs is, gee, if I'm responsible for 24/7, 365, how many times am I going to get waked up? Or, I'm on the golf course on Sunday. How many times am I going to have to respond? And the reality is that we train patients pretty well. They don't want to bother their doctor unless it's very serious. So I think the preponderance of calls that the DPC docs that I'm aware of get after hours and on weekends is pretty small.
Gotcha. Awesome. So yeah, coming out of here, then we've got a couple of things to dig into. Certainly DPC. I've been meaning to come back to it anyway. So let's talk about that and get something going. And
right.
I would like to dig into that. I just looked it up. It's the Dartmouth Atlas, that care sensitive concepts. Mike had some great questions on that. So we'll dig into that a little bit further. And we've got a bunch of other interesting topics coming up. So thank you everyone for coming. We got a health blog here. David Harlow announcing a blog that he's got coming up next Tuesday at 1 p.m. On the general health policy side. And if you all aren't familiar with health blog, that's one of the places to go for policy and HIPAA and really excellent information. So if you're interested in that type of stuff, I definitely recommend checking out his blog there. And yeah, again, thank you everyone for coming. We had a really good turnout today, a good chat. The community seems to be growing. I'm having a lot of fun learning a lot, and that's what it's about. So hopefully you guys are getting a lot out of it too, and hopefully solving some problems.
Thanks, Don. Thanks, everybody.
Yeah, thanks for coming, John. I appreciate it. Everyone have a great day. We'll see you next week.
Take care.